Dr. Mark Pegram is the Susie Wanwei Hung Endowed Professor of Medical Oncology at the Stanford University School of Medicine. He currently serves as the Associate Director of Clinical Research at the Stanford Comprehensive Cancer Institute. He also serves as the Associate Dean for Clinical Research Quality at the Stanford University School of Medicine, and is the Medical Director of the Stanford Clinical Translational Research Unit, a unit specializing in first-in-human Phase I clinical trials. Dr. Pegram's breast cancer research is focused on the study of the cancer-associated gene that encodes HER2 and on the development of novel agents of the treatment of patients with HER2-positive metastatic breast cancer. Ladies and gentlemen, please welcome Dr. Mark Pegram.
Good afternoon and welcome to this Bay Area Cancer Conference breakout session entitled Evolving Considerations in the Treatment and Management of Metastatic Breast Cancer, Expert Strategies for Improved Clinical Outcomes. I'm Mark Pegram. I'm a professor of medical oncology at Stanford, and I couldn't be more pleased to be with you this afternoon for this breakout session. Thank you all for your attendance, and I look forward to your active participation in this session. I'm going to leave plenty of time at the end for a question and answer session that you can do through the chat function, I believe. I couldn't recall whether or not this is a continuing education session or not, so I've listed disclosures for your consideration in case that it is at the bottom of the slide. Now, we have an ambitious agenda this afternoon, obviously covering a topic as broad as metastatic breast cancer in only a 1-hour session is virtually impossible. It's not uncommon for me to attend day-long sessions just on one treatment of one subtype of metastatic breast cancer. So to try to cover everything will be impossible. If I don't cover a topic that you might be the most interested in, again, that's why I want to leave plenty of time at the end so you'll have a chance to bring up topics that, for the interest of time, we may not be able to touch on during the didactic presentation. So we're going to examine the clinical burden of metastatic breast cancer, explore recent efficacy and safety data of PARP inhibitors for BRCA or PALB2 mutant metastatic breast cancers. We'll explore controversy surrounding immune checkpoint inhibition and PD-L1 positive triple negative metastatic breast cancer, and review some practice-changing new data in the treatment of HER2 positive metastatic disease. Now, it's really important to remember the goals for treatment with metastatic breast cancer. Number one is prolongation of survival. However, despite the plethora of treatment modalities available for metastatic disease, significant survival differences are still relatively uncommon, and for the most part, cure sadly remains elusive. There are some exceptions. For example, the exceptional responders with HER2 positive metastatic disease sometimes are apparently cured, and sometimes we have patients who present with oligometastatic disease with perhaps one site of distant metastasis, say, for example, one solitary liver metastasis that's small and can be ablated at the time of adjuvant systemic therapy. Sometimes those patients are treated with curative intent and are apparently cured indeed. Symptom relief is paramount. It's not given as much attention as it merits, in my opinion, for metastatic patients. Maintenance of quality of life is paramount, but all too often I see that treatment side effects are as bad or sometimes worse than some of the disease-related symptoms. So it's a constant tension between quality of life and efficacy signals from current treatment. Delay until the need for treatments with untoward side effects can be a noble goal. For example, in the case of ER-positive metastatic breast cancer, we'll try to use as many lines as endocrine therapy as is possible before we have to embark on chemotherapy treatment to spare all of the side effects of chemotherapy for as long as possible. Another example would be to delay the need for radiation therapy or neurosurgery or both for breast cancer brain metastasis. If you have systemic agents that are well tolerated and efficacious in the brain, sometimes you can delay the need for more invasive interventions. And finally, improvement in progression-free survival. Progression-free survival is typically the primary endpoint for most of our clinical trials. It's recognized by regulatory authorities as a primary endpoint for considerations of new drug registration for new clinical trials, for example. This metric importantly includes both patients who achieve responses objectively, like either partial responses or sometimes even complete clinical responses, where their cancer apparently disappears from all of the radiographic images. But it also includes those patients whose disease may be stabilized with treatment. So if you have metastatic breast cancer and you see your oncologist on a follow-up appointment, and you have a recent set of CAT scans or bone scans or both to go over with the doctor, and if he says everything is stable, he or she says everything is stable, that can be a good day, because sometimes we see long-term disease stability with relatively little or few or sometimes no disease-related symptoms, and that can be very impactful as well. So you don't have to have objective responses to benefit necessarily from many of our therapeutics. Let's first begin with HER2 targeted therapy. The HER2 gene is shown on the left-hand side of this slide in the photomicrograph. This is a fluorescence in situ hybridization, or FISH experiment, where we have probes that will hybridize to the HER2 gene, which is on the long arm of chromosome 17. And as a control, in green, we have probes that hybridize to the chromosome 17 so that we can count the number of HER2 genes per chromosome 17. And if that's greater than 2, then by definition, there must be evidence of HER2 gene amplification relative to the number of chromosome 17s that are present. In the normal situation, you have one HER2 gene per chromosome 17, one you inherited from your father, one you inherited from your mother. But in these tumors that have HER2 gene amplification, which is perhaps 15 to 20% of all breast cancers, there can be 25 or even 50 copies of the HER2 gene in those cancer cells. When that happens, the messenger RNA for the HER2 gene goes way up, and the messenger RNA then encodes for the HER2 receptor protein, which is on the cell surface, and the level of that HER2 protein goes up. The HER2 protein is an enzyme. That's its principal activity. It's a signaling enzyme that launches downstream signaling that results in increases in cell proliferation, motility, migration, invasion, and metastasis. So it is a typical oncogenic protein. And you can see on the right-hand side of the slide, I've done some experiments here where we've introduced HER2 into MCF7 cells that are HER2 negative. And those cells are called MCF7 HER2 cells on the upper right-hand side of this slide. And you can see in the laboratory that the growth of these colonies goes way up when you add HER2 into HER2 negative breast cancer cells. And the same is true on the lower right-hand side of the slide in the case of in vivo tumorigenicity. When you add overexpression of HER2 into MCF7 xenografts, these are human tumor xenografts grown in immunodeficient mice, the HER2 activation will result in larger tumors and more metastasis. And this probably accounts for the poor prognosis of patients historically with HER2 positive breast cancer prior to the advent of HER2 targeted therapy. This was one of the worst subtypes of breast cancer in terms of overall prognosis. We also did experiments where we tried to block HER2. We didn't have siRNA knockdown technologies back in the early 1990s, and we didn't have CRISPR technologies in the early 90s. So we did the next best thing that was available to us, and that is we got some antibodies that block HER2 from our colleagues, Brian Fenley, Mike Shepard, Paul Carter, Lenny Presta, and others from Genentech here in South San Francisco. And when we added trastuzumab, a HER2 antibody, to HER2 positive breast cancer cells on the lower right-hand side of this slide, we found that the percentage of cells that were proliferating, that were making new DNA, going through the cell cycle, the synthetic phase of the cell cycle called the S phase fraction, that percentage dropped way down after treatment with trastuzumab in HER2 positive human breast cancer cells. Whereas in HER2 negative breast cancer cells, they had no response to trastuzumab. On the upper right-hand side of the slide, we had some mechanistic insight into why this was happening. And it appeared to us that as we increased the concentration of trastuzumab in these treated cells that were HER2 positive, the association between HER2 and HER3 was blunted. Ordinarily, before you add trastuzumab, there's some association between HER2 and HER3, but as you increase the trastuzumab dose, that association falls apart. And that's what those black blots tell us in the upper right-hand side of the slide. I'm not going to go through the experimental details. But if you activate HER3 with an activating ligand called heregulin on the far right-hand side of the upper photo on this slide, you can see that that really causes a big black blob of HER3. That means HER3 is associating strongly with HER2. So when you activate HER3 with a ligand, that promotes association of HER2 and HER3, and that is a particularly active HER family dimer. Dimers of HER2 are the most active form of the proteins. Now, when we did this in the clinic, it resulted in improvements in survival compared to chemotherapy alone. In this particular publication, it was a randomized trial of taxotere alone or trastuzumab plus taxotere, also called docetaxel. And those patients who got both trastuzumab plus taxane chemotherapy had the longest survival compared to chemo alone. And the patients who started with chemo and added trastuzumab later, who crossed over during the conduct of the clinical trial, they had a more intermediate prognosis. So this worked, at least in the clinic in metastatic patients, to improve outcomes, including progression-free and overall survival, and it markedly increased the response rate, and it was fairly well tolerated, except for some infusion reactions, especially on the first, sometimes the second dose. Sometimes that requires co-medication with antihistamines or even steroids. And also, if patients had prior anthracyclines or concomitant anthracycline chemotherapy, like doxorubicin, also called adriamycin, then those patients had a higher risk of congestive heart failure with trastuzumab. So you have to be mindful of that in selected patients. Now, this, until recently, was the NCCN guidelines for treatment of HER2-positive metastatic breast cancer. At the top, it starts off in the first line with a combination of two different HER2 antibodies, trastuzumab plus pertuzumab, which is kind of a cousin of trastuzumab. I'll show you more about that in just a minute. If you combine that with a taxane, that particular recipe is called a Cleopatra regimen. And that has a very profound survival advantage compared to taxane and trastuzumab alone. In the second line, until recently, TDM1, which is a HER2 antibody-based drug conjugate, which is a trastuzumab backbone and a chemo drug called derivative of maytansine 1, or DM1, that's linked to the trastuzumab backbone by a chemical linker. Until recently, that was the preferred second-line treatment. And then in the third line, you can see that tucatinib-based treatment was typical. Trastuzumab drugstocan was typical in the third line until recently. And any other combination of trastuzumab with chemo du jour was popular in those days. Margintoximab is a newer version of a HER2 antibody that has more immunologic activity. That also was in the mix. Neratinib is in the mix. So all these were considerations in later lines of therapy until recently. Now let's take a closer look at this HER2 Her3 story for just a minute. This is a photomicrograph of HER2 and HER3 that you can actually see microscopically with these colorimetric labels. In this experiment, HER2 is labeled in green and HER3 is labeled in, HER3 is labeled in green and HER2 is labeled in red in this experiment. And you can see that before you add ligand or before you add trastuzumab, that there are preformed clusters of either HER2 clusters or HER3 clusters. And then if you add a ligand, these clusters will merge as dimers of HER2 and HER3 form to activate downstream signaling that results in cell proliferation, migration, invasion, etc. In panel D and E on the right, you can see the three-dimensional form of the photomicrograph shown in panels A, B, and C, just to show you that there is some structure to these preformed clusters. So HER2 likes to be in kind of pools with each other. So does HER3 until you activate them, and then they like to dimerize. So why is HER2 Her3 dimerization important? We have crystal structure data on the upper left-hand side of the slide showing that ligand-activated HER3 can form very tight dimers with HER2. That brings the enzymatic activity of these receptors in close proximity, shown on the lower left-hand side of the slide. It allows HER2 to phosphorylate HER3. And in the middle of the bottom row on this slide, that is a part of the HER3 molecule that's inside the cell. And there are 6 tyrosine amino acid residues in the HER3 protein structure that are phosphorylated by HER2 when these dimers form. And it turns out these phosphorylated tyrosines on HER3 are docking sites for PI3 kinase, which you may have heard of, is a potent oncogene that launches downstream signaling through PI3 kinase, AKT, and mTOR to cause all of these oncogenic phenotypes of HER2 positive cells. So this is critical. And in experiments where Yossi Yarden in Tel Aviv did all the possible combinations of HER1, HER2, HER3, and HER4, when he did all the possible dimer pairs, the most potent by far was HER2, HER3. And the crystal structures are shown on the upper right-hand side. There's just one interesting feature. The structure kind of in the middle top of this slide is, I believe, HER1 with HER3. But note, the bottom part of that structure is highly reminiscent of cyclin CDK crystal structure. So in evolutionary terms, HER2 enzymes evolved from cyclin CDK enzymes, remarkably. And so perhaps it's no surprise that these are oncogenic. This probably happened over a span of hundreds of millions of years, indeed. Now, back to the clinical data. This is a randomized phase 3 trial called the Cleopatra study, first-line HER2 positive metastatic breast cancer. And in this study, patients were treated with a taxane, in this case docetaxel, with the dual antibody combination of trastuzumab and pertuzumab, compared to docetaxel plus trastuzumab and a placebo. Over 800 patients were randomized. And on the far right-hand side of the slide, I'm showing you the most up-to-date overall survival analysis of Cleopatra. And it shows that simply by adding a second antibody to chemotherapy plus trastuzumab, simply by adding pertuzumab, you gain a 16.3-month median overall survival advantage, simply by adding one more antibody. And this is with 99-month follow-up now. So this is durable. This is a very solid data at this point. And when you add the second antibody, pertuzumab, it doesn't add that much more toxicity. There's a little bit more drop in the white blood count, and there is some more diarrhea, to be sure. And sometimes we have to make dose modifications from the chemo for that, because docetaxel can also cause diarrhea in this recipe. But this is a pretty profound impact. And now this base, this taxane plus dual antibodies, is also commonly used in neoadjuvant therapy of HER2 positive early stage breast cancer, or even in the adjuvant setting. This is a popular combination as well, based on its activity in metastatic disease, first elucidated in Cleopatra. Now, in the second line, I told you TDM1 has been a popular second line regimen. TDM1 was discovered at Genentech by accident. The investigators at Genentech were doing a series of experiments trying to study linker chemistry, where they linked a chemo-like drug called DM1 directly to trastuzumab, and they wanted to know how stable should that linker be. In theory, you want it to be stable enough so the antibody-drug conjugate doesn't fall apart in the circulation before it arrives at the HER2 positive tumor. But the theory back in those days was once it reaches the tumor and binds to HER2, you want the chemo to come loose at that point so that it can diffuse into the tumor cell and kill it. That was the theory. As a negative control for these experiments, they deliberately made a linker that is completely stable. It can't fall apart. It can't release DM1 at the cell surface. And they thought that it would just be stuck there on the cell surface and not do anything. That proved to be the most potent antibody drug conjugate in this experiment, was the negative control. Unbelievable. And then they tried to figure out why, and it turns out that what was happening, as shown on the right-hand side of the slide, the mechanism of action, or MOA, is that the antibody drug conjugate with DM1 is binding to HER2 on the cell surface, but then HER2 is being internalized. And then it traffics to what are called these lysosomes inside the cell, which is like the garbage disposal of the cell. And inside the lysosome, it's a very acidic environment, a very hostile environment, lots of enzymes. That degrades the antibody drug conjugate all the way down to a single amino acid level, and that releases the TDM1 inside the cell, where it can kill the cancer cell from within, literally a Trojan horse-like approach. So really a remarkable discovery and a surprise finding for a negative control to become a very active drug. So this was the FDA pivotal trial that won approval of TDM1. We published a paper in the New England Journal of Medicine showing both a progression-free and overall survival benefit of TDM1 compared to capecitabine and lapatinib. Lapatinib is a pill form of a HER2 kinase inhibitor, and capecitabine is a chemo-like drug. That was the standard of care in the control arm back in the time that this experiment was done on the left. In 2017, we published the updated overall survival data from this Amelia pivotal phase 3 trial, and it has withstood the test of time. As you can see, the TDM1 is still having a survival advantage compared to control on the right-hand side of this slide. So this drug is still available, and until recently was the go-to standard of care in the second line of HER2-positive metastatic breast cancer. More recently, there have been a number of other HER2 targeting antibody drug conjugates that have come to light. There's at least a half a dozen more in clinical development as we speak. This drug, trastuzumab drugstocan, is of particular interest. It is quite distinct from TDM1. It has more of the chemo-like drug attached to the antibody compared to TDM1, 8 instead of about 3 or 3.5 in the case of DM1. This has a cleavable linker, so it's not a stable linker, so it probably may not even require internalization, and it may not require trafficking all the way into the lysosome to kill the cell. Moreover, the chemo drug here is a topoisomerase 1 inhibitor chemotherapy drug. It's a soluble drug, whereas DM1 is not. So after this drug kills a cancer cell, the drug can be released from the dead cell and kill the neighboring cell. So that's an advantage compared to TDM1. And this drug also can be given in much higher dose compared to TDM1. TDM1 dose is only about 3.6 milligrams per kilogram. Here you could give 5.4 milligram per kilogram, which is almost the same as the trastuzumab dose. It's 6 milligrams per kilogram. And that may also be a therapeutic advantage compared to TDM1. So at this year's ESMO, just a few weeks ago, the Destiny Breast 03 pivotal trial was presented by Javier Cortez and colleagues. This was a head-to-head comparison of this trastuzumab deruxtecan, also called TDXD, against TDM1. And the results were unprecedented. The progression-free survival is shown in the upper right-hand side of the slide. This is the primary endpoint of the study. As you can see, the TDXD-treated patients had a much longer progression-free survival compared to the TDM1 control group. The hazard ratio is 0.28. I have not seen a hazard ratio this low in breast cancer history. The p-value is 10 to the minus 22nd. So there's no way this could be a random play of chance observation. This is real. On the bottom left-hand side of the slide, you can see the waterfall plot. Those are all the responders. On the top, the dark blue are the TDXD treated patients, and any blue bar that falls below that blue line is an objective response. You can see there are more of them than in the case of TDM1. And the ones that go all the way to the bottom, on the far right-hand side of that waterfall plot, those are the complete responses, which occurred in 16% of the patients in the TDXD arm. The objective response rate was nearly 80% in the TDXD arm compared to just, I think, about 35% or so in the TDM1 arm. Finally, the overall survival had a non-statistically significant trend favoring TDXD at this point in time. This is still an early interim analysis. There were not many overall survival events, fortunately, so far in this study. So even though the p-value looks to be very low with a couple of zeros after the decimal point, that actually did not reach the statistical pre-specified p-value to be considered as significant just yet. But stay tuned for more updates in the future as this data matures. It looks to me like this could well become significant in the not too distant future. We'll have to wait and see. Also, I should mention that in subset analysis, this advantage of TDXD over TDM1 occurred irrespective of hormone receptor status, prior pertuzumab treatment, visceral versus non-visceral disease, number of lines of prior therapy didn't matter, and the presence or absence of brain metastasis didn't matter. About 20% of the patients on this trial had stable brain metastasis, and it didn't matter. They did just as well on TDXD and had a benefit compared to TDM1. Really remarkable. Now, this huge efficacy signal has some disadvantage. This drug, TDXD, has more toxicity arguably than does TDM1. It is not as easy to give as TDM1. A lot more chemo-like side effects, including low blood counts, nausea, vomiting, diarrhea, anorexia, fatigue, not uncommon, liver test elevation on laboratory parameters, alopecia can happen. And then the most serious side effect of TDXD is shown on the right-hand side on the table, and that is interstitial lung disease, or also called drug-related pneumonitis. And in a previous study of TDXD, which won accelerated approval just last year, there was about 2.7% of patients who actually died from this particular complication in a phase 2 trial. But fortunately, in this study, which is less heavily pretreated patients, this group of patients was about half second line, and the other half were third line or greater, so less heavily pretreated compared to phase 2. And fortunately, there were no grade 4 or grade 5 ILD toxicities in this clinical trial. And that's really critical if we're going to be able to, get the maximal clinical benefit out of this particular new drug. So now there's enthusiasm to move TDXD up into the second line. The FDA has not yet weighed in on this decision. Neither have the guidelines committees, but it is anticipated that both will probably approve TDXD as the go-to second line treatment in the not too distant future. One possible exception could be the subset of patients with brain metastasis. I'll tell you more about that in a few minutes. So the other interesting thing about this TDXD, trastuzumab deruxtecan, is it seems to work even in some HER2 negative breast cancers, as long as they express some HER2. If they're HER2 1 plus or HER2 2 plus on a special stain in the pathology lab, those patients can also seem to benefit, at least in phase 2 studies. And so now there's a phase 3 trial that's ongoing to test this drug in these so-called HER2 low patients. What fraction of all metastatic breast cancer patients are HER2 low? The pie chart on the lower right-hand side of this slide shows that over half of all breast cancers have HER2 low status. That is, they aren't HER2 high, they're not HER2 positive, but they're not HER2 zero either. So this could be a breakthrough treatment for other subtypes of breast cancer in the not too distant future. Next, let's talk about small molecule HER2 kinase inhibitors. Tucatinib comes in a pill form. It's a cousin of lapatinib, which was approved years ago. And tucatinib is unique because it really only hits HER2. Lapatinib had problems. It hit EGF receptor, which caused rash and diarrhea. On the upper part of this slide, there's a comparison of tucatinib on the left versus neratinib on the right. And you can see those pink blobs on the graph in the middle of this slide, just to the left of center. Neratinib has lots of blobs. That means it inhibits HER1, HER2, HER4, and then a number of other enzymes as well. It's not very clean, and consequently, it has a lot more side effects than tucatinib has. So tucatinib was designed specifically to be a pure HER2 inhibitor and not block any other enzymes. So a randomized phase 3 clinical trial was done, which won FDA approval. The trial is called the Her2 Climb study. Tucatinib was combined with trastuzumab plus capecitabine. There was a placebo control arm in this study, but there was a randomization 2-to-1 to the experimental arm. The primary endpoint, again, was progression-free survival. Overall survival was a secondary endpoint. Both endpoints were met with statistical confidence at the time of the first planned interim analysis, and so was the subset with brain metastasis, which was nearly half the patients in this study had brain metastasis. They also had a PFS benefit at the time of the first planned interim analysis. So that was enough to win FDA approval for tucatinib in HER2-positive metastatic breast cancer. The unique feature of tucatinib also is its activity in the brain. And this was actually called out in the FDA approval language. They said, particularly for patients with HER2-positive breast cancer brain metastasis, tucatinib is a unique drug. On the upper left, you can see objective responses. About 47.3% have objective responses in the brain in this HER2CLIMB clinical trial. On the upper right, you can see there's an overall survival, OS benefit, that's statistically significant in patients with brain metastasis in this randomized clinical trial. Also, in the subset of patients with active brain metastasis on the lower left, a survival benefit that's statistically significant. This is unprecedented. We've never seen this in a randomized phase 3 trial before for HER2-positive breast cancer brain metastasis. So this is truly a first. And then finally, on the lower right-hand side of the slide is new brain lesion-free survival. That is the time to develop another brain lesion. And that also was prolonged in the tucatinib-treated patients compared to control. And that's important because when you get a new lesion, you usually need more radiation therapy or neurosurgery or sometimes both. So again, if you can prolong the time necessary to get more invasive treatment, that is also an important clinical endpoint that was reached in this trial. Margintoximab is a cousin of trastuzumab. It's been engineered deliberately to have more immunologic activity as an antibody. Remember, antibodies evolved to fight infections in our bodies, and trastuzumab was simply an antibody that's been redirected against a tumor rather than a bacteria or other germ. And so anyway, this margintoximab molecule is a little bit better than Herceptin in a pivotal randomized phase 3 trial called SOPHIA, where margintoximab plus chemo was compared head-to-head against trastuzumab plus chemo in heavily pretreated HER2-positive metastatic breast cancers. But you can see in these Kaplan-Meier plots in the center of this page that the results are modest. There will be an update in the overall survival analysis at this San Antonio meeting in a few weeks. So stay tuned for that to see if there are some subsets of interest that may have more impressive outcomes. This was enough to win FDA approval, though, so it is available for treatment currently. So the other issue I want to point out is that in the modern era, it's not uncommon for patients with newly diagnosed early-stage HER2-positive breast cancer to be treated with trastuzumab, pertuzumab, and chemo in the neoadjuvant setting, and then maybe adjuvant TDM1. So by the time, if they relapse to a metastatic disease situation, they've already used up those first 3 drugs. So this concept of line is becoming blurred. And I think we're just going to have to simply be content with, instead of calling these lines of therapy, simply call out what the patient's prior therapy has been and how long has it been since they had that therapy and how well did they tolerate it, et cetera, instead of using this concept of lines for the future. Next slide. So in the wake of the ESMO 2021 trastuzumab deruxtecan data, this is a new proposed guideline for trastuzumab deruxtecan in the second line. And yet for active central nervous system metastasis on the right, shown in orange, tucatinib is still arguably favored because of level 1 evidence from a randomized phase 3 trial of a survival benefit with statistical significance. Tucatinib still carries the day in that subset of patients, and that's why that's called out specifically in this algorithm, as well as called out by the FDA in their approval of tucatinib. Now, what I've shown you over the past few minutes is that we've converted a negative prognostic factor, HER2 amplification, into a favorable predictive factor for response to therapy. So we've literally converted a negative into a positive in the case of HER2-positive breast cancer. In the modern era, with all these effective treatments, the HER2-positive breast cancer patients now can do better than HER2-negative breast cancers, ironically. So it's taken too long, but we've made some inroads in that regard that we've converted a negative into a positive. Next, believe it or not, there's a little bit of a connection between HER2 and BRCA1. They are both located on the long arm of chromosome 17. And in fact, years ago, in the early 1990s, I went to a genetics meeting at Cold Spring Harbor, and they were debating what the familial breast cancer gene was. And HER2 was still on the short list of potential genes back in those days because it's located fairly close to the HER2 gene on chromosome 17, ironically. The pie chart on the right shows the complex landscape of familial breast cancers and the numerous different types of mutations that have been associated with familial breast cancer. Of course, BRCA1 and BRCA2 are the prototypes. Just to show you where we're at in terms of testing in the recent era, in the quote on the right-hand side of the slide at the bottom, March 22nd, 2017 in Science News, quote, according to current data, it's estimated that only 30% of breast cancer survivors with BRCA mutations have been identified, and that number drops significantly to about 10% for asymptomatic BRCA mutation carriers. So we have a lot of work to do in the United States. We have not identified all of the BRCA1 or 2 mutation carriers yet in this country, much less all of the other genes of interest that have been associated with increased risk. So we have a long way to go in terms of testing. And now the testing issue has become paramount because we have effective drugs now to treat BRCA1 and BRCA2 mutations and probably also PALB2 mutations. And these drugs are called PARP inhibitors. PARP is a protein that's important for repairing single-strand DNA breaks, which happens thousands of times during each cell division, these DNA nicks. If such nicks persist unrepaired until the DNA is replicated, then the replication itself can cause double-stranded DNA breaks to form. So drugs that can inhibit PARP1 cause multiple double-stranded DNA breaks to form in this way. And tumors with BRCA1, BRCA2, or PALB2 mutations, these double-stranded DNA breaks cannot be efficiently repaired, leading to cell death, particularly in cancer cells and not in normal cells that have intact BRCA1 or 2 and can repair double-stranded DNA breaks. So PARP adds these sugar groups called ribose sugar groups to these areas of damaged DNA, and those sugar groups are like a red flag, and it calls in a whole complex of DNA repair enzymes that then repair the damaged DNA. But if you have impaired BRCA function as well, that can't be fixed. And if you block both PARP and BRCA, it's called synthetic lethality. That alone can kill the cell. Next slide. So there are PARP inhibitors that have been approved by the FDA for treatment of BRCA or 2 mutated metastatic breast cancer. The Olympiad trial shown on the left shows a progression-free survival advantage of olaparib, and on the right, talazoparib in the Embraca trial showed very similar results. There are side effects of these drugs, particularly cytopenias, fatigue, GI upset. Anemia is very common with both of these drugs, so they're not without toxicity. This drug class has also been associated with myelodysplasia or even acute leukemia, rarely. So as clinicians, we have to be on the lookout for that as well. Recently, there's been an adjuvant study called Olympia that also showed benefit of olaparib in early stage BRCA mutated breast cancer as well. So these drugs are now approved and are available for treatment consideration in our metastatic breast cancer patients with BRCA mutations. PALB2 is also an enzyme that's involved in this double-stranded homologous recombination DNA repair pathway. And Josh Gruber at Stanford on the left showed that talazoparib can also cause clinical responses if patients have inherited PALB2 mutations. And on the right, data from the Translational Breast Cancer Research Group, TBCRC, showed the same thing with olaparib. So PALB2 germline mutation carriers with metastatic breast cancer can also be considered for PARP inhibitor therapy and have some hope of a nice response. Next, let's talk about triple-negative breast cancer. It is the most aggressive breast cancer subtype, highly invasive, high metastatic potential, tends to have relapses early with poor outcomes. It's more likely to occur in younger patients. About 46% of triple-negative breast cancers will have distant metastasis at some point. Median survival after metastasis is very modest, very sobering indeed. This subtype of breast cancer accounts for about 15% of all breast cancers. The 5-year mortality rate is 30%, which is unacceptable. So we need much more attention to this subtype of breast cancer to be sure. To that end, immune checkpoint blockade was recognized by the Nobel Committee back in 2018 for Hanjo and Allison for their use of immune checkpoint antibodies that block PD-1, PD-L1, or other checkpoints indeed. And so this now has been translated into breast cancer clinical trials. The Impassion 130 trial was a combination of atezolizumab, which blocks PD-L1. And you can see on the left-hand side of the slide that when combined with nab-paclitaxel, which doesn't require steroid pre-medication, that these patients had a progression-free and an overall survival benefit. In the middle of the slide, those are the two Kaplan-Meier plots. Top is PFS, bottom is overall survival. Now, there was a confirmatory trial for Impassion 130, Impassion 131. And Impassion 131 used paclitaxel, which does require steroid pre-medication. And unfortunately, the Impassion 131 confirmatory trial, as you can see on the upper right-hand side of the slide, is negative. So the FDA and Roche retracted their accelerated approval of atezolizumab in triple-negative metastatic breast cancer recently, unfortunately, on the basis of a negative confirmatory trial. Meanwhile, pembrolizumab, a PD-1 antibody, has shown both a progression-free and overall survival benefit in the Keynote 355 trial, shown on the lower right-hand side of this slide. That's the progression-free survival data, and I'll show you the overall survival data next. This is the overall survival analysis recently updated at ESMO, showing that this pembrolizumab molecule, when combined with chemotherapy, has superior survival benefit in these triple-negative breast cancer patients. So this is now considered a standard of care for the management of PD-L1 positive triple-negative breast cancer based on this data set. Now, these checkpoint antibodies do have these immune-mediated adverse events, endocrine disorders, thyroid disease, inflammation of the lung called pneumonitis, inflammation of the colon called colitis, skin rash. So clinicians have to be mindful for these, be on the lookout for them. If you encounter them, they have to be treated. Sometimes this requires drug discontinuation, may require administration of steroid medication, et cetera. So this is an important caveat with the integration of these drugs into our therapeutic armamentarium indeed. I propose, based on new technologies developed at Stanford, that it may be possible to really characterize the immune microenvironment of breast cancers in a very precise way using new technologies of labeled antibodies, either labeled with heavy metals or labeled with barcode nucleotides. And that way you can measure all the different subtypes of immune cells in a tumor specimen quite easily. And so it's hoped that with these technologies, we'll get better markers than PD-L1 is. PD-L1 is not a great marker. In fact, it doesn't work at all in the neoadjuvant setting for pembrolizumab, for example. So we need better biomarkers to figure out who's going to benefit from immune checkpoint inhibition, and PD-L1 is not the holy grail. It's better than nothing, but I think we can do much better with newer technologies, and these are being studied now for this reason. Next, let's talk about antibody-drug conjugates in triple-negative breast cancer. Here's a new antibody-drug conjugate called sacituzumab govitecan. There'll be a quiz afterwards to see if you can remember these names. I'm not responsible for the nomenclature. I would make it something easier to remember. This also has a topoisomerase 1 payload, just like trastuzumab deruxtecan has. It's a different topo-1 inhibitor, but the same drug class. And it has linker chemistry. And the target here is a protein called TROP2, which is internalized just like HER2 is. So when an antibody-drug conjugate binds to TROP2, it flips inside the cell, and the antibody-drug conjugate gets incorporated inside the cell, releases the payload, and kills the tumor cell. The randomized phase 3 trial that won accelerated FDA approval and ultimately final approval more recently is shown on this slide. The schema is on the left, and the progression-free and overall survival are shown for your interest on the right. Both are highly statistically significant. There was a clinically meaningful overall survival benefit that was also statistically significant, and now this is available to us also in metastatic triple-negative breast cancer, primarily in the third line of treatment. This ladiratuzumab vedotin is another antibody-drug conjugate that can be used in clinical trials. It's currently in use in triple-negative breast cancer studies. It also may have activity in ER-positive breast cancer as well. Here's a treatment algorithm for triple-negative disease, starting with immunotherapy and then moving to chemotherapy and antibody-drug conjugates. PARP inhibition is, of course, available for BRCA-mutated patients. And finally, I'll make one comment here on an algorithm for hormone receptor positive, HER2 negative metastatic breast cancer. These patients are typically started with a CDK4/6 inhibitor along with an aromatase inhibitor. That's the most commonly used first-line treatment. In the second line, patients typically move to a fulvestrant-based regimen, and this can be used in combination with a PI3 kinase inhibitor if the tumors are PI3 kinase mutant, and if they're not mutant, it can be combined with an mTOR inhibitor, for example. So this is the classic schema right now for ER-positive metastatic breast cancer. This is some of the data. There are 3 CDK4/6 inhibitors. They all 3 have almost identical objective response rates of about 55%, and the Kaplan-Meier plots on the right-hand side of the slide look superimposable. There is one that recently has come to light as having a survival benefit in the first line when combined with an aromatase inhibitor. This is Ribocyclip. So it has been proposed that this might be currently the favored CDK4/6 inhibitor in the first line setting for ER-positive metastatic disease until we get more mature data, perhaps, with the others. These are the clinical trial data that led to approval of PI3 kinase inhibitors at the bottom of the slide and mTOR inhibitors at the top of the slide. Both have progression-free survival benefits. Both have important toxicities as a caveat. For example, PI3 kinase inhibitors can cause hyperglycemia, fatigue, and skin rash. mTOR inhibitors can cause mucositis and other problems like fatigue as well. Just to keep you posted on clinical trial developments, here's a trial of an AKT inhibitor. So that's downstream of PI3 kinase and upstream of mTOR. And this looks good in a randomized phase 2 trial in luminal breast cancer as well. So stay tuned for phase 3 trials in the future regarding AKT inhibitors. Finally, I'll finish up with this topic of selective estrogen receptor degrading agents. There are about 6 of these agents in clinical development at the present time, as well as selective estrogen receptor conformation changing agents called SERCAs. And these drugs are highly active, even in estrogen receptor mutated cases, and they can be given as a pill form instead of fulvestrant, which requires an intramuscular injection. Some of the side effects of some of these drugs are a little bit odd, like bradycardial visual disturbance, diarrhea, not typical of what we're thinking about with endocrine therapy, but this is typical of this drug class, some unusual toxicities we're going to have to face up to. Finally, PROTACs are a way to degrade the estrogen receptor, a whole unique new class of drugs that's entering phase 1 clinical trials as we speak. Very interesting mechanism of action and highly active in preclinical investigation. So the take-home messages for this hour: antibody-drug conjugates have dramatically changed the landscape in patients with HER2 positive and triple-negative metastatic breast cancer. New tyrosine kinase inhibitors like tucatinib have shown to improve HER2 positive breast cancer patient outcomes, particularly with breast cancer brain metastasis. Immunotherapy-based strategies seem to be the preferred approach in patients with PD-L1 positive metastatic triple-negative breast cancer. PARP inhibitors should be considered for patients with germline BRCA mutations and probably PALB2 as well, although the number of patients in the PALB2 studies is still small. And finally, new selective estrogen receptor degrading agents, SERDs, are in clinical development and at least preliminarily have promising results and could replace fulvestrant with a pill form, which will be much better for our patients. Thank you so much for your attention. And if possible, we have some moments left for questions, debate, discussion. I'll turn it back over to Erica for your comments.
Wow, thank you so much for sharing all of that knowledge that you somehow keep in your head. Very much appreciate it. We do have time for a few questions, so I'll dive right in.
Great.
One of the first ones is wondering whether Ibrance only delays progression of metastatic disease, and if resistance to Ibrance is shown, will that make other targeted treatments or chemotherapies less effective?
So Ibrance is one of the CDK4/6 inhibitors that I showed briefly. It's a cousin of ribociclib and abemaciclib. It was the first CDK4/6 inhibitor to be approved by the FDA. Basically, the overall survival data for palbociclib in first-line ER-positive metastatic breast cancer when combined with an aromatase inhibitor. The overall survival data have not yet been presented. And that could either be a good or a bad thing. It could be good if those patients are doing so well to have very long survival. The longer the better, until you finally meet a statistical threshold that calls for analysis of the data with statistics. On the other hand, if we wait really long, perhaps it means it's not going to have a survival benefit. Then that begs the question, does that mean that it doesn't have a survival benefit at all? In other words, like the question alludes to the fact maybe it only has a PFS benefit and not an OS benefit. But I doubt that that's the case. Remember that these overall survival endpoints require many more patients to have the same statistical power as PFS. So all of these studies that I've shown you all afternoon have relatively less ability to show a survival benefit, even if it exists, compared to the PFS primary endpoint. So it could be play of chance if the palbociclib overall survival analysis is negative. It could simply be play of chance, I must tell you. So what does that say about resistance? All three CDK4/6 inhibitors can and do have resistance mechanisms. There's a myriad of such mechanisms that have been proposed. Having a basal phenotype, for example, is a strong predictor for lack of benefit for CDK4/6 inhibitors. And there's a number of other receptors, FGF receptor, for example. Some literature has described trapping of PARP inhibitors inside organelles inside the cell that can sometimes also be a mechanism of resistance. That happens in triple negative breast cancer in particular, for example, in the literature. So yes, there are resistance mechanisms, and it's likely that patients who are resistant to CDK4/6 inhibitors probably don't respond as well to subsequent lines of endocrine therapy. You know, that's probably true. We have some data from alpelisib in a study called the BYLieve trial, where they wanted to see whether alpelisib, the PI3 kinase inhibitor, still works even after prior CDK4/6 inhibitor progression. And it showed that it does still work, but the results didn't look as impressive as the SOLAR-1 trial, which were in patients who never had CDK4/6 inhibitors, for example. So it is probably true that the CDK4/6 inhibitor progressors, you know, may not do as well in later lines of endocrine therapy and may need to go into chemotherapy at some point in the future as a consequence.
Thank you. I guess time will tell, and we'll just have to wait until the data pans out.
That's right.
I know you addressed the prospect of using PARP inhibitors with BRCA1 mutated cancers and suggested that it might be used for PALB2 as well. Are there any use for them with CHEK2 mutations? And if possible, can you comment on the trial that included CHEK2 mutations at Stanford that seems to now be closed?
There are these studies at Stanford and TBCRC that included CHEK2, ATM, P53, I believe, and others. And those did not fall out in those data sets as being responsive to PARP inhibition. The caveat to that statement is that the number of patients with those mutations in those studies is still very small. So I don't know that we can rule out a response rate that may be modest for CHEK2 mutation carriers treated with PARP inhibitors. I don't know that we can rule it out on the basis of what limited data we have yet, but the data available so far do not suggest that we should be treating CHEK2 mutation carriers with PARP inhibitors just yet. The same is true for ATM and other genes as well.
Okay. Since we started late, I'm going to try to sneak in one last question. I know it's a big one, but maybe you can just comment very quickly as to what the biggest challenge is for developing new systemic treatments for ER-positive diseases.
One of the biggest challenges are ER mutations. And the good news there is that many of these new selective estrogen receptor degraders and these PROTAC drugs may be able to tackle, all or at least a lion's share of the common estrogen receptor mutations. So that's a plus. So these new drug classes, I think, are going to be the next breakthrough in the management of estrogen receptor positive breast cancer.
I think we all very much look forward to that, especially an oral drug. That would be wonderful.
The last thing I'll leave you with is remember that though the survival results are always depressing in metastatic cohorts, and I apologize for showing so many Kaplan-Meier plots, but remember that metastatic disease is a testing ground, and many of these drugs will, if they're tolerated well enough and if they're safe enough, will move forward into a curative disease setting, and hopefully in the not too distant future result in an increase in cure rate, which we've seen steadily at a 1% to 2% per year rate over the past 10 or 15 years in newly diagnosed breast cancer. I expect that will continue with the promise of all these new active agents in metastatic disease that will hopefully translate to increased cure rates with newly diagnosed earlier stage disease. So keep that in mind.
Yeah, thank you for leaving us with that last hopeful thought. And with that, I'd like to thank you very much again for spending time with us, sharing your knowledge, answering our questions. And I'd like to thank the audience for staying with us and being engaged. The breakout sessions are now over, and it's time to return back to the landing page and click on the link to the plenary session for the last plenary talk of the day. So I hope you're all enjoying the day, and we'll head over and listen to Dr. Spiegel.